Now the inflammatory condition of larynx, it consists of the acute epiglottitis, the acute laryngotracheobronchitis or croup, and the third is the laryngeal diphtheria. Now first we will be discussing about the acute epiglottitis. So write down, it is very important topic. Acute epiglottitis is the rapidly progressing cellulitis of the epiglottis. So very important, it is a rapidly progressing cellulitis of epiglottis. So it is basically a inflammation of the supraglottic part of the larynx. So it is also known as supraglottitis. Now what is the age group? In which age group we see this condition? We will see this condition in the 2 to 6 years of age group. So very important. This is basically a acute airway emergency. This condition, that is the acute epiglottitis, is a acute airway emergency. And what is the most common organism which is causing this condition is the bacteria by the name of Streptococcus pneumoniae. So Streptococcus pneumonia is the most common organism. Earlier it was H influenza type B, but with massive vaccination, this H influenza type B, the cases have gone down, and now the most common organism is the strep pneumoniae. Now what is the clinical features? As I said, this is an acute emergency, so the patient will present to you in a OPD or in casualty with acute onset fever. So the patient will have acute onset fever, and as there is the presence of abundant subcutaneous connective tissue below the epithelium of this patient, so any inflammation of the supraglottic area or the epiglottis, it will lead to the prolapse, it will lead to the swelling or the prolapse. So the patient will have a inspiratory stridor. So the patient will have an inspiratory stridor. There will be a respiratory obstruction. Now in this, the child will typically present to you in a tripod position. So the child will be holding the edges of the bed and he will be sitting like this. He will be leaning forward. The child is leaning forward and he will be holding his neck like this. So this will cause the more airway. So it will buy time. So the patient is basically trying to improve his respiration. So as the patient is having a inspiratory stridor. So this is also known as tripod position because it resembles a tripod which we usually see, on which we put a camera. So the patient will present to you in emergency with acute onset fever. There will be inspiratory stridor. The child will be in a tripod position, and since it is involving the epiglottis, so the child will be having drooling of the saliva. The child will not be able to swallow his own saliva because of odynophagia. Odynophagia is nothing, it is painful swallowing. So the child will be having odynophagia, acute onset fever, inspiratory stridor. The child will be in a tripod position, but the voice of the child will be normal. So this is a clincher over here. If the voice of the child is normal and the child is having all other symptoms just now what I have described, that is 100% the child is having a acute epiglottitis, and we should basically avoid examination of such children because it can precipitate the respiratory obstruction. If you are trying to see the epiglottis, the swollen epiglottis, so this will basically it will cause the airway obstruction. It can lead to airway obstruction. So patient on X-ray soft tissue neck, the patient will be having a thumb sign. It is because of the swollen epiglottis. Now if you carefully see this X-ray soft tissue neck, this is a swollen epiglottis. So it is like a thumb sign. So it will be like a thumb sign. So this is known as the thumb sign. It is a feature which is seen in acute epiglottitis. Now what is the treatment of such patient? The treatment, it includes antibiotics. Write down antibiotics. Why antibiotics? Because it is a bacterial infection. So we will give a antibiotic to this patient, and we will also give steroids. As you all must be aware that the steroid basically it reduces the edema. So it can basically reduces the edema, and it will improve the patient's the stridor. Patient is having an inspiratory stridor, so the respiratory obstruction will be improved. But if the patient condition gets worsened, we will be doing either an intubation or a tracheostomy in this patient. So always remember, any patient coming to you in emergency with acute onset fever, the patient is basically a child, 2 to 6 years of age group, and the patient is having inspiratory stridor. He may or may not be in a tripod position. The patient will be having drooling of saliva because the patient is not able to swallow his own saliva, but the voice of the patient will be normal. And if you get an X-ray soft tissue neck, you will see a thumb sign. The treatment, it includes antibiotics, steroids, and the plus minus intubation or tracheostomy of such patients. Now we'll discuss another condition which is also which is also infection of the inflammation of the larynx, and it is the acute laryngotracheobronchitis. It is also known as croup. So it is the most common infectious cause of airway obstruction in the children. So write down beta, croup is the most common infectious cause of airway obstruction in the children. It is laryngotracheobronchitis. So what we read in basically acute epiglottitis was, it is the infection or the inflammation of the supraglottic part of the larynx, whereas the croup, it involves the other part of the larynx, that is the vocal cords, the subglottis. It either involves the trachea and the bronchus in this patient. So the most common cause of acute laryngotracheobronchitis is the para-influenza virus. So write down, the most common cause is the para-influenza virus, and the age group in this condition is 3 months to 3 years. So the patients, basically the subglottis, it starts from the subglottic part of the larynx and it progresses down to the trachea and the bronchi, and the boys are affected more commonly as compared to the girls. So boys are more commonly infected as compared to the girls. Now what are the clinical features of such patient? The patient will be having a gradual onset fever. Remember, in acute epiglottitis there was a sudden onset fever. In this we will be having a gradual onset fever. The stridor in this will be, the stridor is, to start with, it is inspiratory, but as the condition progresses, it descends down. The stridor, it becomes biphasic or expiratory. The cough of the child will be barking cough. So this is a pathognomic of croup, that is acute laryngotracheobronchitis. In the MCQ they can ask you, the child has come in 4 years of age or 2.5 years of age, and the child presents with gradual onset fever with a barking cough. So barking cough is basically the pathognomic of acute laryngotracheobronchitis. Here the voice of the patient will be hoarse. So hoarseness is seen in acute laryngotracheobronchitis, whereas if you remember in acute epiglottitis the voice was normal. Now you order a X-ray AP view for the patient of acute laryngotracheobronchitis and you will see a sign. So in both in acute epiglottitis you are seeing a sign, that is the thumb sign, and in X-ray of acute laryngotracheobronchitis you will see a steeple sign. Now what is a steeple sign? This is the X-ray of the patient who is having the croup. So if you see here carefully, it is involving the subglottic part, that is, it is swollen, and if you see the rest of the trachea, it is also swollen, but it is not that much, the airway obstruction is not there. So it resembles basically the steeple. If you have been to the church or if you have seen the church from outside, you will see the, on the top of the church there is a steeple which is present. So this basically resembles the steeple of the church, and that's why this is known as the steeple sign. So in acute epiglottitis you will see a thumb sign, whereas in acute laryngotracheobronchitis you will see a steeple sign. Now what is the treatment of this patient? The treatment of this patient is, we give the patient humidification, then we nebulize this patient with epinephrine to reduce the edema. We also give decongestant, and as steroids are important for the for airway obstruction, so we give local as well as the systemic steroids, and plus minus we can go for intubation or tracheostomy. So remember the treatment of the patient, we are not giving antibiotics here. The antibiotics are given in acute epiglottitis, but we may give antibiotic because it may prevent any kind of secondary bacterial infection. So antibiotics can also be added plus minus, as primarily this condition is mostly viral in origin.